Okay. Good evening, everyone, and I welcome you all to another session under our YUVA ARSI initiative, the second episode of Scalpel Society. Today's webinar theme is Financing and Policy in Rural Cancer Care, a topic that sits at the intersection of equity, access, and compassion. I'm deeply honored to have with us a leader who redefined rural oncology care, someone who chose purpose over privilege and built a system where no patient is denied treatment due to financial constraints. Please join me in welcoming Dr. Ravi Kannan, Director of Cachar Cancer Hospital and Research Center, Silchar. It is always a moment of pride for me to converse with someone who has walked the same corridors of Maulana Azad Medical College, or I would say I'm lucky to walk the same path they already had. Coming from the same institution, albeit 3 decades apart, I feel a deep sense of connection from the times I started planning for this webinar. I'm privileged to tell about his life journey so far. He began his journey as a young medical student at Scalpels Medical College, Chennai, and his passion for surgery deepened as he completed his MS in general surgery at the Maulana Azad Medical College, New Delhi in 1995. And then he got trained in surgical oncology at Adyar Cancer Institute, where he served as a head of the department as well. In 2006, a single visit to Cachar Cancer Hospital and Research Center, Silchar, changed everything. He left behind his Chennai career and dedicated his life to uh, provide free cancer care to the underserved thereafter. There are so many feathers on his cap. He received Mahavir Award in Medicine in 2013. He was honored with Padma Shri, fourth highest civilian awards of India on 26 January 2020. He was recognized with Raman Magsaysay Award, the highest award in Asia in 2023. He was recognized with the CNN News 18 Indian of the Year 2023. This is the place CCHRC built by him to address the cancer gap, rural cancer care gap, which was there because of limited access to oncology services, financial constraints, late diagnosis, travel burden to the distant city. CCHRC was initially built as a small facility, but now it is in a comprehensive care center, which is offering surgical, medical, radiation oncology, pediatric oncology, and palliative care services. Even diagnostic services such as pathology, radiology, PET-CT scanning, the molecular diagnostic, and it provides cancer prevention, early detection, community outreach programs, home care, and telemedicine services for the patient who are unable to travel. In HRC, the 75 to 80% of patients receive free or subsidized care. Rural care provided via community outreach program, early screening initiatives, tele-oncology, home-based care model, and all these initiatives led to increased access to the cancer care, reduced financial burden, improved early detection, and community empowerment. And this is another side of Ravi sir enjoying this session organized by the students in his alma mater in September 2024 is reliving, cherishing, and sharing the memories and imparting learning in the students of Mansi. So, for the key learnings for this session, the sustainable financing is critical, which can be achieved by low cost of for services, the treatment subsidy, boarding and lodging, no to dual pricing, active counseling for patients and caregivers, registration to proactively determine and offer support. Community engagement is the key, which is achieved through home-based care, recruitment of medical social workers from the community, home-based screening by the ASHA workers, building communities against cancer. Policy support enhances reach. Everyone who visits the hospital will walk back with a follow-up date, reach out patients on phone, will provide them unskilled labor employment in term of daily wages and one-time payment for the patient who registers for the care. And compassion-driven care matters, and citizens of Valley form the Cancer Society and hospital out of felt unmet need and telemedicine through satellite care. So these are the key learning. Now moving to the second part of the session, which I'm eagerly waiting for, and I'm sure you are also excited for the same. So before welcome you, sir, and before we get into policy and financing, I would like to ask you one question. What was that one moment that made you choose rural career, cancer care over a thriving urban career? Over to you, sir.
So it is not a one moment thing. we came, as you mentioned, in the hospital was established by lay citizens of the valley, a few doctors, but a lot of non-medical people. And uh, so after the hospital was established, their then director, Dr. Chinmay Chaudhary, went about visiting cancer centers, and he spent time with us at the Cancer Institute in Chennai. And then after he came back, he used to keep referring patients for care because he was very impressed by the philosophy of the Cancer Institute that the socioeconomic status of the patient should not dictate whether or not the patient gets care. And then when I left the institute, he referred a patient, one thing led to the other, and we came on a visit to Silchar. When we came here, my wife, Sita, my daughter, and I, three of us visited for a week. And I spent time in the hospital. Sita spent time in the community. Before we could go back, Sita said there's a lot of need here, and this is what we should be doing. And that is how we ended up coming here. When we went back, she initiated discussion in both our homes. She resigned from work, and then we came here. We initially planned to stay for a few years. 5 years became 10 years, became 15 years, and now it's almost 20 years. We are here.
Sir, moving on to the next question, like how did the geography and the delayed diagnosis affect outcomes in regions like Barak Valley?
So, the unfortunate thing about our medical education, it focuses a lot on the science and on the skills required to treat and cure people. But other equally important aspects of healthcare, like like looking at the cost benefits, looking at the socioeconomic background of the patient, looking at the compliance to care, looking at the follow. These are all uh, aspects that are less emphasized during our training programs. And so when I came here, I was actually ill prepared for the problems that we found. And each time there was a problem, we would settle it, just like firefighting, we would settle it, create a process, and move on. And I think even today, that is what is happening. Neither do we have the resources to plan, 5 years, 10 years, 15 years, and implement the plan. And nor were we well equipped in terms of knowledge to anticipate what all. Now, because of experiences that we have gained, we have begun to anticipate what can go wrong. In the initial years, we never did a cost analysis. We never did, planning for a patient. We did not have a kitchen. And one day we discovered a child eating some puffed rice. And we said, oh, tomorrow we start a kitchen. Tomorrow we started the kitchen. We didn't know where the money would come from. We didn't do the planning, but we started. And a lot of what happened over the last many years happened organically. There was a need, and we found a solution to satisfy. There was a patients were not coming because they were losing wages. We looked at ad hoc employment. Patients were not keeping appointments, so we looked at fixing up appointments. Patients were not able to travel, so we went out and created satellite centers. Sick patients were not able to travel to a hospital, so we started home care. So like that, based on the needs, we created solutions, and this is what has happened.
And what was the most surprising fact when you first visited there, like when you started working there?
The thing that that hits you most, especially in the earlier years, was the see. I used to think patients in Chennai, patients who came to the Cancer Institute, were poor. But poverty in different places has different dimensions, and the kind of poverty that we experience next year is both amazing and also very uh, troubling. The kind of trouble patients take to in order to access healthcare. The kind of things that they will sell in order to raise resources in order to come and get treated sometimes can be heartbreaking. And that has its own repercussions. So when a breadwinner, see, 80% of our patients are daily wage earners. And so what happens when the breadwinner has to come to the hospital again and again for himself or for a family member? Kids, in Assam, education is free. There's no tuition fee, there is no books, uniform. But then kids will drop out of school. Why will they drop out of school? Because the breadwinner is not able to continue. So they will. The other day, just 2 3 days ago, I had a patient with an advanced cancer. She was accompanied by a 15-year-old daughter. And so, just to start a conversation, I asked her if she was the gunda at the family. And she laughed and said she has to make the decisions. So I asked, no father? She said, father is there. Father works in Haflong. It's a town in a neighboring district. So will he not come? He cannot come because he is unwell. So I asked, no brothers and sisters? She said, two brothers, and she's the only daughter. So I asked, elder brother? She said, elder brother. So where is he? She says, Videsh mein kaam karta hai. Then I said, what Videsh mein? The mother says, he works in a hotel in Bangalore. So I asked, how old is he? She says, he is 16 years old. So I said, 16 years, how did he land in Bangalore? She says, her sister's son, who works in Bangalore, took him and put him in because 1 year ago the father had a stroke. And now the woman is having an advanced ovarian cancer. There's a younger brother who's in class 2. And so the 16-year-old has dropped out of school and he has to earn. Imagine what kind of a future, and he's working in a hotel probably as a cleaner or a servant. And so when we were discussing amongst ourselves, we said this child and the younger brother's innocence has to be protected and their education safeguarded so they don't lose out on life. And then the other thing that will happen is, even if you treat an individual and the individual is cured, many of them will not go back to active livelihoods. And so by treating somebody, we end up creating another problem in the family. So when we treat patients for chronic illnesses, for heart disease or cancer, if we don't keep in mind the loss of livelihoods, the loss of education, if we don't pay attention to all of this, by treating somebody, we will actually inadvertently, we think we are doing good because we are saving somebody's life. But all the other collateral damage that happens, will ruin that family. Curing and saving somebody's life will lose meaning if they don't go back to a good life. And so these are things that we have to grapple with as healthcare providers. In a big city, many times all these things are lost in the hurry of life. Whereas in smaller towns where there are more close communities, these things become very important.
Now, next question is from my side is like CCHRC provides care to the majority of the patient free or subsidized. So, how do you sustain this model?
See, I actually believe low cost cancer care is possible, very much possible. So if you look at surgery, the cost of consumables, you look at anesthetic gases, you look at IV propofol, muscle relaxants, you look at antibiotics, you look at sutures, all all together will not cost you more than 8-10,000 rupees for a surgery. And so if you're doing a mastectomy, you don't really have to charge, a large sum of money for a mastectomy or even a bigger surgery, a gastrectomy. If the expensive consumables are usually staplers. You will know that. And so you can, and where lot of places you can manage with suturing. It may take 10, 15, 20 minutes extra, but to do a GJ or to, you don't need to staple every time. You can, there are certain areas where a stapler, very low anterior resections, where staplers will prevent a permanent colostomy. Except for those specific situations, many situations you can, do hand suturing, and so you can reduce the costs of surgery very easily. Same way, if you look at medical oncology, if you look at chemotherapy, the margin between the purchase price for the hospital and the MRP is phenomenal. You can buy paclitaxel for 1,000 rupees, less than 1,000 rupees, and the MRP will be some 14-15,000 rupees, and that margin can be shrunk. The hospital, if the hospital wants to offer low cost care, we can reduce the costs. And then, and so instead of selling it for 15,000 rupees, what we do, we have a 20% charge in order to pay pharmacy salaries, and we will sell it at 1,200 or 1,300 rupees if the patient has to pay. Same way, when we see we're a not-for-profit hospital, long ago we took a decision that all our infrastructure has to come from CSR or from public philanthropy. And so we don't we long ago we took a decision that we will not take a loan to put up any infrastructure. If I take a loan, if I have to buy a radiation machine for 20 crores, then I'm all the time bound to repay the loan. The return on investment becomes a very big issue. And where will that return come from? It has to come from patients only. And so we will not put up any infrastructure on us. So we get CSR support. Early years it used to be difficult, but over time the laws have also changed. CSR has become mandatory. Also, as the hospital gets more known, funding becomes easier. And so I'm not at all bothered. So I can easily, if I have to offer radiation to somebody, endoscopes for example, the endoscope has been donated. And so if I have to repeat and a check, I give chemo radiation to somebody and I have to do a check endoscopy, I don't have to charge the patient. You understand? So there are several ways in which we can reduce the cost. So patients used to pay some 100 rupees or 150 rupees, valid for a month as outpatient consultation. And then we realized that if they come for 12 months in a year, they pay 12 into 150, and that is a barrier for them. So we quickly did our math and said we charge 500 rupees for a lifetime, there is no further charge. Immediately, so we did our math because we found that that is what we were earning as outpatient charges. So if we did 500 rupees, only patients who report newly to the hospital pay. All follow-up charges, there's visits, there are no charges. Immediately compliance improves. For the patient, there is a reduction in cost. You understand? And so there are several ways in which we can. Food is another thing, when they come to the hospital. Initially, we started providing food for patients, and then we realized the caregivers also. So you supply food for caregivers, it reduces costs of care. And then, there's daily wages. I used to think that is the biggest game changer, but actually we did an audit and we found while we treat 2,000 patients, only about 20-25 patients ask for ad hoc employment. But what happens is when we do all these small little things, all of it together conveys a message to the patient that if we go here, they will be treating poor patients means you have to make sure that you maintain their trust 10 out of 10 times. You cannot afford to falter at any point of time. And so if we create a hospital that looks fancy, that has marble, that has, it will intimidate. See, all of us, when we go out, when we see a very fancy looking hotel, we will not go in easily. But if we see a smaller, modest looking hotel, we will be happy to go and eat there. Hospitals are like that. If you create a glitzy looking hospital, poor patients will be intimidated. And so we took a decision that we will have clean, but we'll have simple, you know. So it also translates into lower costs of maintenance. And so little by there are several ways, if we just put our minds, we can actually provide low cost but good quality care. Low cost treating poor patients doesn't mean you provide less than standard of care. That will be cheating, And then the other good thing that has happened, two good things have happened in the country in the last few years. One is in 2013, we started what is called the National Cancer Grid. This was led by Tata Memorial Hospital. And so we now have nearly 350 organizations that are part of the National Cancer Grid. And as National Cancer Grid, so we want to establish uniform standards of care across the country. We want to help all institutions develop human resources to provide these services. We want to promote multi-center India contextual research. And then we want to make sure we get involved in public policy. And so the National Cancer Grid, we all of us together bargain for costs. So if I as a hospital negotiate with a company, they will give me a certain cost. If 10 hospitals join together, then the cost will be lower. If 300 hospitals bargain together, the cost of the equipment or the cost of the drug will be a lot lower. So because we are a large group, there is strength in working together. And so that is one of the things. The other thing is, public interest. PMJY has come up. There are other NGOs and organizations offering support, and these have offered ways to subsidize costs of care. So, in addition to what we are doing, the milieu around us has also changed over the years, making low cost, good quality care really possible.
And which of the funding streams has been the most reliable throughout?
So today, if you ask me, 70-80% of our revenues comes from the PMJY schemes. But there are also other schemes in the government, the PMNRF, the MLA's funds, there are other government, and then there are private organizations like the Indian Cancer Society, the Mahesh Memorial Trust, the NM Budrani Trust. There are several organizations like that, you know, Can Kids. There are several organizations that support patient care in their own ways. Some of them are age specific, some of them are gender specific, some of them are agnostic, some of them will only provide consumables. So like that, but if you work with all of them, the only thing that is required is you have to diligently provide the reports of what you're doing. But there is a lot of help in our community today that helps us sustain this.
And what lessons can other institutions learn from your model? What few lessons? Like,
So if somebody is interested in so there are organizations, there are hospitals that will look at people at the apex of the socio-economic pyramid. Nothing wrong with that. That is what they look. Everybody requires care. Rich people also require care. Poor people also. The way you will manage rich people may be different from the manner in which you will manage poor people. But the quality of care cannot be any different. What you will offer, you may offer expensive drugs that may offer a 2 month survival benefit for a man or a woman who can afford it. For somebody who is at the lower end of the socioeconomic pyramid, You may not offer drugs which have very small benefits. You understand? But other than that, quality of care should not be different. Okay. But then, if you are looking at supporting people at the bottom of the pyramid or under the pyramid, it is very much possible. There are resources available at the bottom of the pyramid also, and so it is not a non-viable situation. You don't have to think that somebody who works in a poor-friendly hospital, the personnel have to be poor. They don't have to be. They can earn enough to send their kids to a good school, to put up a house, to buy a car, to live a reasonably good life. Is very, and then there is also a lot of academic fulfillment. That you can be part of teaching programs, you can be part of conferences, you can. So it is a perfectly viable situation at the bottom of the pyramid as well.
And does at any point of time this policy supported or limited your work, and which one needs most the urgent attention like in your work?
Come again, please explain again.
The policy which has been made, either the policy made by the government which has been like in support or limit your work in the hospital, or it's like something which is need
So,
attention
so
right now.
the policies happen at two levels. One is what the government frames. These are statutory requirements. These are legal requirements, and these must be complied with. Otherwise, it's the law of the land. The other set of policies are what are framed by the organization. So those are organization specific in response to the need in the community. For example, we have a policy that anybody who walks into the OPD will be seen the same day. We will not tell them that there is no time today, you go and come back tomorrow. As a result, what happens sometimes, OPDs extend for long hours, 8 o'clock, 9 o'clock, OPDs function in the evening. This is because patients come from far off. They spend money. They take time off work. They make arrangements for people at home. And so when they take all this trouble, and if they have to come from a place which is 200 kilometers, they sometimes land up late in the afternoon. And we cannot turn around and say today's appointments are closed, you go away. And so this is a local level policy. But then government level statutory requirements like the Clinical Establishment Act or the Fire Safety Act or the police, these are all mandatory laws that we have to comply with.
And how important is the community participation throughout your
Extremely
daily life?
important. Extremely important. See, we are working for the community. And so it is good to take the community as a partner than as a recipient. You understand? It is not that we are doing something that we will gift the community. The community is part of. We are there because the community needs us, and so to work alongside the community, to engage with the community, to go out, talk to them, to engage them in activities in the hospital. We have a scientific advisory committee. We have an ethics committee. We are trying to see how we can give patient representatives on all these boards. So we are planning a public policy for patients. We often call patients and find out if this is what they would like. When we go into the community, when we have community level programs, often we will work with community representatives to see if something better could be done, if they have inputs on to how something can be. So these are, but then we're also learning. We're not at the in the top of the game as far as community engagement goes, but extremely important to keep the community, to work with them rather than to hand out solutions to them.
So, is there any situation or example you've remembered, like where the community has like
Yeah, so we started with the community level early detection programs. And so when we first started off, we said we will train ASHA. Initially, we said we will train the ASHA to examine people in their homes And then we said, after the end of the project, we said it's too cumbersome. What happens if we engage with the Asha to just create awareness? And so during the course of this, somebody from the community suggested, why don't we also involve other departments like the Panchayat Raj system? And so we thought that is so we are working only with the health department. But if the same messaging could be delivered by other departments, by Anganwadi, by the Panchayat Raj, by the school system, by the police, by the public distribution system, the messaging will be so much stronger. And so we actually tried this out in another district in Lucknow. We started a multi-sectoral convergent messaging program, all because we learned something from the. Somebody said, "Why don't you put display posters in the fair price shops, in the ration shop, because everybody goes there?" So he said, "Oh, we must do that." Then somebody said, "Why don't we engage with the elected representatives in the Panchayat Raj?" So we said, so then when we started researching, we actually found that in 2017, the government has come out with a proposal for a multi-sectoral convergent messaging involving more than 20 verticals of the government. So we had policy backing also, but all this happened because somebody in the community suggested, why don't we do this? On our own, we were focused only on the health department, working, creating awareness, doing. So you learn from engaging with the community.
And how have this telemedicine and outreach programs reduced patient burden?
So telemedicine actually started as a project. The Department of Information Technology has a wing called MAITI, Information and Electronic Technology. And so they have CDAC, Center for Development of Advanced. They have CDAC centers in several cities. So the group in Mohali had a telemedicine software that they wanted to test in the Northeast. And so they worked with the local NIT. The director of the NIT at that time, Dr. Deshpande, knew us. So we were a non-government organization. Despite that, he chose us as their partner. And so we put a telemedicine center in two of the districts around us. The project got over in a year, but then the telemedicine centers continued. We had recruited healthcare workers whom we trained. And to start with, we said we started delivering all the home care for those two districts from those satellites. And now we have satellites in Barigram, in Dharmanagar, in Haflong, in half a dozen places we have satellites. What happens is the uh, a typical clinic in a satellite center sometimes will see as many as 80, 90 patients. A lot of patients prefer to come to the satellites because they don't have to spend money on travel. So now we are trying to expand the activities in the satellites currently. We do follow-ups, we do evaluation, we do endoscopy, we do all that. We're now trying to see if we, on a small experiment, we delivered chemotherapy for a couple of patients. It worked well. Somehow we have not been able to scale that up as yet. So now in two of our centers in Barigram and in Haflong, we are trying to see if we can start delivering chemotherapy. And this chemotherapy we want to deliver on our clinic days. And so it's actually taking care closer to the homes of the population will improve compliance, will reduce costs of, will overall improve access to care. And I think that is how we must plan all our health deliveries.
And how to work on primary and secondary prevention of cancer in rural areas and switching the focus from just therapeutic to a more comprehensive
So
approach.
this is very important, Cancer is caused by tobacco, alcohol, um, areca nut, dietary preferences and practices, inadequate physical exercise, and some infections and inflammations. Just 4 or 5 causes account for almost 70% of cancers in the country. If you remove these 4 or 5 causes, very likely that the incidence of cancer will reduce. But pause there. If you look at heart attack, why do you get heart attack? Because of tobacco, alcohol, dietary preferences and practices, inadequate physical activity. Why do you develop a stroke? Either a blood vessel gets blocked or ruptures. Why do you get tobacco, alcohol, dietary practices, lack of. Why do you get, why is diabetes more prevalent? Why is hypertension, tobacco, alcohol, and then some of these NCDs, diabetes will increase the risk of heart attacks and strokes, hypertension, and some cancers as well. Hypertension will increase the risk of um, heart attacks, and so some of these renal failure, blindness. So some of these NCDs will give rise to other NCDs as well. And so when you change your lifestyle, when you don't use alcohol or areca nut or tobacco, when you pay attention to what you eat and how you prepare your food, when you pay attention to levels of physical activity, when you make sure some of your vaccinations are intact and you attend to your infections quickly, you're actually preventing a whole lot of diseases. You're promoting health in the community. Very low budget activity with very high impact in terms of health and in terms of economics. And so this is a very important activity that every one of us should be involved in. All the hospitals, should strive at making the hospital irrelevant because everybody is healthy in the community.
Now my next question is like, how does your hospital address rehabilitation and patient's dignity? Like, what they.
This is a challenge. So rehabilitating patients after, so we have a perihabilitation ward, where we help patients before they start treatment, and then we also focus on rehabilitation. But it's a big challenge because there's no one answer to all the outcomes of treatment. Some of them will have a colostomy, some of them will have a tracheostomy, some of them will need crutches, some of them will need calipers. Above all of them will need rehabilitation to get integrated into the community in terms of livelihood, in terms of food, in terms of going out, in terms of confidence building. And this is something we are trying to institutionalize. And we have some groups trying to help us create alternate livelihoods. We're also trying to work with the Skill Development Council. See, we our patients are, most of them are cared for by a family member, and when the patient gets cured or the patient dies, that skill is lost. And so we are trying to see if we can certify that learning, working with the Skill Development Council, so that we create people who are certified for home care, for care of sick people. This need is going to increase as our population ages. As more and more young people go out for employment, there will be elderly people, there will be sick people who need to be cared at home. So we're trying to see how we can do all of these. Time will tell how good we will be.
And what is your vision for rural cancer care in the next decade? Is it you have some.
I really hope that more and more youngsters will see the value of going and settling in rural communities, to see the joys of living and working in rural communities, because the quality of living is far superior, and the impact that you will have on your communities is also far more visible than what will happen in a big metro. And so and only when we have equitable distribution of hospitals and medical personnel will healthcare really be universal in this country. And so that is something that I hope will happen over the next few years. I lost
Uh,
you. Yeah.
Yeah, sir. Am I audible now? Yeah. So before moving on to the end of the session, there are some questions from the participants which has been posted in the chat box.
Okay.
Alicia, can you please read out the questions to me? I'm not able to.
Yeah.
Yeah, sure.
Hi. So Satyajit asked, what is your advice for aspiring surgical oncologists, and what are the things to keep in mind before starting working in rural areas?
See, my thought for surgeons is, respect surgery, respect the tissues, spend time in becoming a master theoretician. My professor, Dr. Sarda, always used to say that sound theoreticians make sound surgeons. And so that is my thing for surgery. But also remember, you were a doctor first, and then you became a surgeon, and then you became a surgical oncologist. So always practice surgical oncology, especially in rural areas, because very often you may be the only person or one of the very few people around. And so you must have a wide variety of skills. You should be able to work as a physician at some place. You must be able to work as a radiologist on an occasion. You must be able. So it is good to cultivate multiple skills to equip yourself to be more wholesome when you are in the community in rural areas. Remember, at all costs, if you keep the interest of the patient, if you make sure that if some goodness can be spread, you can be an instrument in it, you will do very well. You will be widely respected, widely loved, and very successful.
The next question I had was, how do you keep the model sustainable with adequate remuneration for all the staff?
So this is a challenge. So this requires some degree of buy-in from your colleagues also at all levels. And so when we when we when we recruit people to work with us, this clarity must be there. The clarity of what the earnings will be like, what will be the support systems available, what is it. This conversations must happen not once, but must happen many times over and over and over again. So we don't lose sight of the overarching rule, overarching um, purpose of the organization and the purpose of everybody in it. Unless everybody aligns with the purpose of the organization, it will be misery. And so this conversation must happen. Somebody who has differing aspirations cannot work in a situation like this. This clarity must be there. And then if somebody has differing aspirations, it is good to part as friends. You understand? Very important.
Dhanya wanted to ask if how does PMJY cover the actual cost incurred by you?
Yeah, PMJY in many situations will cover the consumable costs. It may not, if you look, costs come by way of consumables, then come by way of maintenance, electricity, water, AMCs, CMCs, and then comes by way of salaries. So if you put all of it together, PMJY will not cover everything, but PMJY will cover a substantial part of the costs. Otherwise, you won't be able to treat the patient. He or she will not have even that money. In the early years, we used to get small amounts of money from patients, and that money used to be, what we had. When PMJY came, when Indian Cancer Society started supporting, when NMBT started supporting, we were able to treat a larger number of patients. Yes, it does not cover the entire cost, but we are still able to do a lot more than what we were doing earlier.
Deepak wanted to ask that are high-end investigations really needed for any type of cancer, or can they be skipped with respect to cost-benefit ratios? So, by high-end investigations, he gave an example of PET scan or bone scan for managing all breast cancer patients.
So, all patients do not require high end investigations. that is for certain. And these guidelines are very clear. So in the National Cancer Grid, we published a set of things called Choosing Wisely India. So we listed out several things that we should be doing or should not be doing. Same way, a PET scan is not required for all stages of cancer. It is not required for some cancers in any stage. And so you have to be evidence based. That is very important. Whatever you do must fit in with standard guidelines and must follow standard recommendations. And so PET scan certainly is not required for everybody.
And so the next question was a lot of the follow up guidelines for follow up of cancer survivors are based on Western literature and guidelines. So, how do we deal with these challenges in
Right.
our
As
setting?
part of the National Cancer Grid, we are we are now engaged with the third edition of the treatment guidelines for cancers in India. And these are all tailored to Indian conditions, Indian patients, and Indian physicians. And so we are keeping in mind not only the disease, not only the science, but also the socio-economic conditions, the travel hazards. All of this is being kept in mind when we are making recommendations. A lot of times, the follow-up does not need to be as stringent as the treatment itself is. And so we're trying to create guidelines that we as Indians can use in this country. And probably several third world countries could follow them as well.
Sir, and just to confirm, these national cancer grid guidelines are available publicly for free
Yes,
access.
yes, 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 yes. At the NCG website, these are available.
That's nice. Sir, are there any shifts in cancer epidemiology you have observed in the decades of your
Yeah,
work?
yeah, yeah. This
There?
is this is this will happen in every country, in every community. So, for example, in lung cancer, there was a time when all lung cancers were tobacco-related cancers, and now slowly, especially in more urban metros, in Mumbai, for example, about 30-40% are adenocarcinomas. Okay, they are not related to smoking, but possibly related to environmental pollution and things like that. If you look at uh, oral cancers, when I was in Chennai, the bulk of the oral cancers used to be gingivobuccal cancers. And they have now shifted in Chennai. A lot of the oral cancers are now tongue cancers. Whereas in our own community where I work, we still see the bulk of our cancers still are gingivobuccal cancers. Same way, there was a time in Chennai where the bulk of cancers used to be hypopharyngeal cancers, and now in Mumbai, in Chennai, in Mumbai especially, most of them are laryngeal cancers. But where I work, we are still seeing a predominance of hypopharyngeal cancer. Laryngeal cancers are very few. Esophagus, we used to see all squamous cell cancers, and now there's a migration to adenocarcinomas of the OG junction. These changes are happening across the country, and they will happen as lifestyle changes, as affluence increases. Epidemiological shifts are inevitable.
So it's really nice how high flow institutes and keeping a research oriented base like Cachar Cancer Center will help us document these and manage them better. Vishwas is asking that there is a gradient even among people with limited resources. So, how do we customize the goal of treatment for them from poor to
So,
very poor to, yeah.
so, 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 where cure is the goal, there is no customization. Somebody who has to be cured deserves everything that can be done. Where question is of palliation, where we are looking at quality of life. We don't necessarily need to invest in high-end treatment modalities and drugs for palliation to be achieved. And then when there's a question of small scale advantages, you need to sit down and talk with the family. and it's important that we don't give them false, you know, uh, expectations. This is a this is a this is a this is both a science and an art to be able to talk to the patient and to be able to help them reach a reasonable decision without you thrusting your opinion on them. You know, this is something. It's a skill that you have to acquire.
So the next question we have is that there are very few doctors who selflessly choose to serve rather than earn. But this cannot have a broader reach. So, what is the role of lobbying the government bodies to increase their responsibility and expand their reach?
So, firstly, I don't agree that there are very few doctors. There are very many people who are working in very far-flung areas and doing amazing, amazing work. And and the only way we can make sure treatment is universal is by making sure that doctors and nurses and technicians in hospitals are spread out across the country rather than focus on, you know, bigger cities. And this is, in a democracy, we are the government. We only elect the government, you understand? And so to say it is the government's job and not my job in a democracy is not right. We are as responsible as the government is, and so we have to partner with the government in order to make this happen. The government is trying to create rules by saying after MBBS you must work in a rural area, after MS you must work in a rural area, after MCH you must work in a rural area. Yes, it is important that we also, many times, you know, individuals will try and get out of this agreement by paying up money. That is not a solution. And so we, as part of the uh, quality of the country, we must be as invested in making this happen. This requires conversation. More than lobbying with the government, this requires conversation amongst us as medical personnel.
Thank you, sir. Sir, my question was that what are the most important challenges faced by the Cachar Cancer Center currently?
Money is the most important thing. Human resources are a very important part. So it is a challenge. What you mentioned, no, the doctors don't want to go and work in smaller towns. So human resources are a problem. You know, to get people to come and work in a place like Silchar is it has its own set of challenges. The access is difficult. It rains so much of the time. There are challenges. The geography and and then infrastructure, because it is partly related to money, but also maintenance is a problem. In Chennai, if an equipment breaks down, if I report in the morning, afternoon somebody will be there to service it. Here sometimes it takes 2, 3, 5 days for somebody to come from some other place. So I think these are, and then of course our own communities, you know, their degree of awareness, their willingness to come and get treated, to convince them. They're all, many of them are poor and they're afraid that if they go to a hospital, they will be out of pocket, that their whole property and whatever they have will be lost. And so to convince them that this does not have to happen, that they will be supported through the journey is a challenge.
So the next question is by Surya, who asks, why can't, what is the role of doing an MCH specialization? Why can this not be done by a general surgeon itself?
Yeah, yeah, correct. See, surgical oncology, more than the degree, it is the training. So whenever you go for training, you learn certain principles, you learn to think in a certain way. As a young surgeon, I would have seen a carcinoma rectum and I would have gone ahead and done a abdominoperineal resection or an anterior resection. Because I trained, I realized, you know, you can use chemotherapy, you can use radiation therapy, effectively in order to improve the patient's chances of cure, improve the patient's chances of a sphincter conservation, improve. So this is just a matter of training. You can get the same training even without formally going through a surgical oncology program. Why did I choose surgical oncology? Because as a surgeon, as a MS general surgeon, general surgery resident, more than half our surgeries were for cancers. Cancer of the breast, cancer of the thyroid, cancer of the stomach. And so there was it provoked an interest in cancers and cancer surgery for me. And that is why I chose surgical oncology. And now I realize that because I trained as a surgical oncology is a broad specialty. Like today, you can straight away after MS general surgery, you can straight away do GI surgery or endocrine surgery, or you can do all that also. But I realized that as a surgical oncologist, I had a wider exposure to many things, which serves me well where I am located. If I were working in a bigger hospital in a bigger city, I may not need to have the skills to do so many different things. There would be other people to support me and do other things. In a smaller town, it helps if you're able to do many things. You help more patients that way.
Yes, sir.
Vibha, I'll hand it back to you.
Yeah. Sir, my few last questions for you. One word that defines your journey. It's a rapid fire round for you.
My one word that defines my journey is exciting.
Nice. One myth about rural healthcare.
That it is a very difficult job. That there is no money in rural healthcare. That you cannot grow in rural healthcare.
And one message to the young doctors like us.
Always, always keep the sick man and the sick man's family as the only factor in making your decisions. Nothing else should matter. And whenever you can do some good, don't put boundaries. Do everything that you can to do the good that you can.
Thank you so much, sir, for being with us for today's session. And it's lovely being talking with you, conversing with you, and had the session with you. Your journey is not just a inspiring, matlab it's a blueprint for the change, and we enjoyed a lot. I think everyone have enjoyed the way
So I have
I did.
something to say. Any of you wants to come and spend some time with us here in Silchar, you're all more than welcome. You want to come for 2 days, 10 days, 2 months, come. You're more than welcome. We'll be very happy to host you here. All the best. God bless all of you.
Thank you so much, sir.
Bye bye.
Bye bye. Good night to
Good
all.
night.
Thank you for joining for the session.
Bye.
Thank you, sir.